And a very warm welcome to everyone to tonight's webinar from Catholic Distance University, cdu.edu. Our topic tonight, as all of you are aware, decisions of life and death. All of us are aware of the crises in health, the end of life, crises that affect all of us and affect our families and our friends. When faced with these life and death situations, we often ask very important and even heartbreaking questions. And we ask those questions in times of stress, in times of exhaustion. And among those important questions are we dealing with these death and life issues, the end of our lives, the end of our relatives' lives, in ways that are consistent with the teachings of the Church? Are we actually benefiting our loved ones? And are we making sound moral decisions, sound prudential judgments in care and those end-of-life decisions? All of that is going to be a topic for us tonight, coming on the heels, as all of us know, with the recent passing of Alfie Evans in England, coming on the heels of that, of the recent case of Charlie Gard. So end-of-life issues, euthanasia, how do we care for the dying? These are pressing topics for today. And to deal with all of that, I have the distinct pleasure of being joined tonight by Steven Bozza. Professor Bozza teaches for us at Catholic Distance University the field of moral theology, but he's also an expert not just in moral theology, but in bioethics and family life. He is the head of the Office for Life and Family for the Archdiocese of Philadelphia and is one of my favorite faculty members here at CDU. Steven, welcome.
Thank you for having me, Matt.
Well, we have a lot to cover tonight, but I also want to invite all of you here in the audience to submit your questions. If you go to the right of your screen, you'll see that you can post questions to us tonight. And there is, as I was saying, quite a bit to discuss. I know that you have questions already lined up because we've been receiving them from you in anticipation of tonight's webinar. But let's get the ball rolling with this conversation with Steven Bozza. Steven, let's start with the most basic of questions. If you were advising a family facing difficult medical situations and likely end-of-life issues, what is the first piece of advice that you give to anyone in what is that difficult situation?
My first response to them would be to probe your physician and know how to ask the right questions. Because in my experience here working for the Archdiocese and also in the practice of bioethics, what I find is that many people don't know the right questions to ask. And so therefore, if they're not going to ask the correct questions, they're not going to get the answers that they need. And I'm not one for faulting the physicians for hiding things, because I don't think they do that, at least the physicians that I've had the privilege to work with. But yet they're not mind readers. Mm-hmm. And so we have to be able to ask the right questions. For instance, if a person is, if a physician's asking a person, you know, I think it's time that you guys make some decisions on the care of mom or dad or whomever. Well, mm-hmm. the very first question that needs to be raised with the physician is mom in a state of medical futility? Now I'll explain what that is, because most people don't know that even exists. Mm-hmm. And so, but that's really going to be helping us to make a determination. So what is medical futility? Futility tells us that there is nothing more that any physician can do to stop the inevitable, which means death. And so there's a process and a way of kind of exploring that, but the physician needs to be asked directly, is mom or dad or my husband, wife in a state of medical futility? Mm-hmm. And we can't accept the response that we can make a case for it, because right. you can make a case for anything. And we don't want to do that. We want to know the facts. We want to know the clinical facts, yes or no. And then if there's something else that could be done, then we have other assessments that we have to make.
Well, you've already started using the terminology that is consistent with end-of-life care with those who are in the end stages of life, but also those who are facing medical crises that could be genuinely life-threatening. You just use the word futility, for example. That has, I know, a very specific meaning in the case of medical care, of bioethics. For those who are uninitiated, lay people who find themselves in these dire medical situations, what's a piece of advice that you can give them to, we don't have the time, for example, to study up on terms for preserving ideas of medical act, of DNR, DNI, all of that terminology that you can be bombarded with by a physician. So what do you advise somebody who has no experience in this, but who can be easily bedazzled and sometimes even bulldozed by a medical practitioner?
Yeah, I think we have to think forward. And one of the ways that we think forwardly today is through, say, tools like living wills or advanced directives. And we could talk a lot about that if you want.
Yeah.
But it's, you have to come into an understanding of these things before they fall in your lap. And so I would recommend people who have healthy family members, who are healthy, to check out a few resources that many publishers have these days. I can tell you, I wrote a little pamphlet. If it costs $1.50, it costs too much, with our Sunday Visitor a number of years ago, that gives people the basics. All they need is the basics to help start the conversation. You know, that's why our work with this in CDU is so very important for deacons. You have a bioethics certification course for our deacons. But it's so important to get the clergy to understand these things, because I tell you, we can't fault them for not knowing. I mean, a lot of times the people in seminaries today are getting good bioethics, and that you know that those individuals, those men are coming to understand a little bit more of the nuances that could help a parishioner in these times of need. But you know, you have older priests now who've been in the ministry for 10, 15, 20 years that, you know, that unfortunately don't have all the updated information that they need.
Yeah.
And so you can't fault them for that. So my recommendation has always been, look, speak to your parish priest or your deacon. And if they don't know, then call the National Catholic Bioethics Center. I've had a 20-year relationship with these men and women there, and they are very, very open to doing consults. You need to speak to somebody that knows more than you do, so that they could help navigate these waters that we find ourselves in.
Yeah, exactly. And these seem at times now pretty deep waters. I want to read something from the Catholic World Report written by Christopher Altieri just a few days ago with regard to the case and death of Alfie Evans. And he notes that it raises issues that must be addressed. He writes, and I'm quoting, "Tragically misguided medical ethicists have made quality of life a controlling criterion for determining whether to give care, and in some places like the Netherlands, even applied the standards in a way that leads medical professionals to participate in the deliberate termination of life. In jurisdictions like Iceland and Denmark, somewhere between 95 and 98% of the pregnancies returning a positive result from a Down syndrome screen and in termination." So we're looking at the wholesale extermination of children with Down syndrome. In your time of study and your work in the Archdiocese and elsewhere, I know, how have you seen, or can you chart sort of the deterioration of medical ethics, and how did we get here?
Well, the issue of quality of life is extremely subjective. And I've often told people who come into my office or my students, stay away from that term, because my quality of life may be different than your quality of life, or may be different than somebody else's quality of life. I'll give you an example. One of my cousins is close to 60 now. He has Down syndrome. Can't do what you and I do, but he's as happy as they come. You know, he lives with his sister and her family, and, you know, he has a job, and, you know, that doesn't pay a whole lot, but you know what? He's got a great quality of life.
Right.
happy. And so and John Paul had spoke about this too, and cautioned people about using that term as well. I think it's better to talk about human flourishing. Is this person going to flourish? Is this person going to be able to live what is normal for that person? So in terms of the term quality of life, I don't use it, and I don't recommend people using it because it's not something that's very dangerous. The devolution, I think, of ethical standards has, and I've thought this out, and I've worked it through, and I've talked to other people about it. Look, when we've decided that we could be the arbiters of when life begins, it's a short move to decide when life ends. That culture of death, that's where it starts, with the whole contraceptive mentality, and the idea that if you're not going to be perfect, then you're not going to be able to live the life that you want. So there's social conditions involved with this. There are theological conditions involved with this. It's a general movement towards, I know better than anybody else. That moves into the medical profession oftentimes. We've gotten into this place because it's if you look at the medical schools, if you look at what people are being taught, death is a part of life, which is a true statement, but it's also not something that we ought to be causing.
Yeah, understood. So we're already getting quite a few questions from the audience, so I want to jump to those. This is actually from a physician he's asking, instead of the family studying ahead of time, as a physician, he would recommend that the family ask the physician to explain the circumstances at what is described as a blue-collar level. Do you find that works?
Yeah, I do. And I think that it's the onus is on the medical professional to bring things down so a person could understand it, yes. But we ought to be educating ourselves as well, and doing what we can to learn some of these things. It's not like this isn't going to be necessary. It's not like this is a luxury. We need to learn it for ourselves, and also, physicians today with healthcare being the way it is, they don't have time to sit with you. When you're going into a doctor's office, or if you're in a hospital, the doctor will do his rounds. They have X amount of minutes to spend with you before they move somewhere else. Right. So is it just to ask the physician in this climate to spend the half hour or the 40 minutes to explain some of the things that you need to explain? I don't know if that's possible. I mean, he's the physician, so he would know.
Right.
But we have to do what we can to educate ourselves.
Yeah, and oftentimes you end up actually spending more time talking either with the nurse practitioner or the nurses on the ward. And
absolutely.
Yeah. Well, that was a question from Dr. Paul Carpentier, so thank you very much. I want to come back to the technical questions, but I want to sort of establish something very early on here, and that is, I want to read a quote from Pope Pius XII, in which he said that life, health, all temporal activities are in fact subordinated to spiritual ends. And in light of that, could you sort of lay out for us some of the groundwork for an understanding of redemptive suffering? I ask that because one of the things that we hear so much today is this reluctance to impose any kind of suffering, that has to be alleviated, even at the cost of killing a patient or a loved one, in the name of avoiding or alleviating suffering. And we'll deal with pain management in due course, but talk about redemptive suffering for us.
Well, in terms of healthcare and in terms of a person's health, we could do the best we can to alleviate pain, and we ought to. It's inhumane to have someone reeking with pain and not being able to do something. At the same time, we're not going to be able to get rid of all of it. We can get rid of what we can, but we're not going to be able to get rid of all of it. And then, as Christians, we're very, very fortunate to have the theology and the knowledge and the revelation that we can join our sufferings to the sufferings of Christ for whatever the reason is. You know, look, it's redemptive. My suffering is redemptive to me because it calls me to look inward. What am I doing wrong? What is it that I need to deal with? What is it that I need to seek repentance of? All those various and sundry things. But it's also redemptive for the person who is watching me suffer, because that object of suffering, as John Paul calls it, St. John Paul calls it, causes me to come out of myself to serve you in your suffering.
Mm-hmm.
And frankly speaking, that's my ticket to heaven or my ticket to hell.
Yeah.
And so, you know, suffering has meaning for both the sufferer and the one who witnesses the suffering. And it's up to us to take that and bring ourselves to a place of repentance, forgiveness, whatever it is that we need. And when we decide that we don't want somebody to suffer, if I decide I don't want to suffer, I rob myself, or you rob your loved one, from having that process of seeing the things that need to be corrected and to enter into eternal life.
Mm-hmm.
Because
and
we
I would
block that out. We block that out.
Yeah, on a personal note, I would encourage anyone, especially under these circumstances, to read John Paul II's magnificent document, Salvifici Doloris,
Yes.
which looks exactly at what you're describing. So with that in mind, let's jump to another question. And this is, would it be okay to ask for resuscitation of any kind, or do we just let the person die naturally?
Well, that's a very complex question, because it takes us to a number of other issues. So let's look at resuscitation first off. We should do what we can do. If we're looking at a need for somebody to be jump-started, whether it be through the paddles or what have you, all these things can be done and maybe should be done. But we have to look at the assessment of benefits and burdens. What are the burdens of doing this? And so if you have a person who is in frail health to begin with, maybe an elderly person whose bones aren't all that great, and you know, is that resuscitation going to do more harm than good? Well, yes, in that instance, yes. And so we should, at that point, legitimately put on do not resuscitate order on this person.
Okay.
Because that whole process could be overly excessively burdensome for that patient. But then again, there are other issues and other circumstances where that wouldn't be the case. And so we're talking about proportionate or disproportionate care right now.
Okay.
And we'll explain that as we go along.
I was going to say that those are two of those technical terms that we all have to grapple with. So when we're talking about proportionate and disproportionate, let's put that as Dr. Paul suggested. Let's put that in blue-collar terms. Okay.
In blue-collar terms, proportionate care is something that will offer reasonable hope of benefit. And I'm emphasizing that term benefit because that sentence has been reworked by certain ethicists that is not correct. It's reasonable hope of benefit. And that would be proportionate to this particular patient's care. But a disproportionate care would be something that doesn't offer reasonable hope of benefit, or something that the burdens are more are going to be more pronounced than the benefits. That's what we have to look at. What is the assessments of benefits and burdens? If the burdens are becoming too great for a person, then we don't need to go there. You know, so you know, if there are more benefits than burdens on this, well, then we ought to consider. going through it. And again, we can't make blanket statements in a forum like this because we don't know the facts of the case.
Right, right.
We
But it's helpful to have a certain set of guiding principles, which is what the church offers consistently. I think that would be a fair statement.
Yeah. Oh, absolutely. Yeah, absolutely.
Now, in a way, we're also talking about obligatory versus optional medical means or medical care. And how do we tell the difference?
Well, that which is ordinary care also offers reasonable hope of benefit, but it's also something that is done almost routinely. It's something that is not experimental, not burdensome. Extraordinary and ordinary care is important, and we have to be doing that. We're obliged to do that. We're not obliged for extraordinary care.
Mm-hmm.
And extraordinary care is something that is experimental, that is, not offering reasonable hope of benefit. That's basically disproportionate to a person's care.
Mm-hmm.
It can be experimental. I think I may have said that already.
Mm-hmm.
I'll give you an example of how in medicine today things are moving and shifting. Back in the 70s, cardiac bypass surgery was only done in Houston, and it was not something that insurance companies were, apt to, to pay for, and it would cause, and they really didn't have a good track record. Today, it's like taking your tonsils out.
Mm-hmm.
You get, I mean, not as it's more severe, obviously, but it's done all the time. It's always covered. It's going to work most of the time. And so that moved from extraordinary care to ordinary care. Mm-hmm. In the 70s, we did not have to do that. In this new millennium, then that's ordinary care, and we're obliged to go through that if other circumstances prove that we can tolerate that.
Right.
And again, we have to know the facts of the case.
Yeah, the specifics of the case. Relative to that is you used the term a little while ago, do not resuscitate. For anyone who spends much time around emergency rooms or with patients who are in end stages of disease, or very frail, one of the terms that you hear all the time is DNR, DNI, AND. What are some of those terms, and what are some of the things that as Catholics we need to look out for when doctors are describing them or suggesting them?
Well, first off, we have to look at the healthcare facility, because the facility itself takes it upon themselves oftentimes to change the definition of what a DNR is. Do not resuscitate has everything to do with cardiopulmonary resuscitation.
So by way of example, that would be things like the paddles, the famous.
That would be the paddles, that would be,
right.
Whatever else, the mouth-to-mouth, or whatever else that person needs to do to start breathing again. Mm-hmm. Some facilities I know are construing DNRs to mean do not give certain types of medications, don't give they have levels, DNR1, DNR2, DNR3. That's baloney. A DNR specifically is cardiopulmonary resuscitation, period, bottom line.
Okay.
We can't let that morph into anything else.
Mm-hmm.
Okay. The problems that I see with DNRs is when they're put on a living will.
Mm-hmm.
We should never do that. Simply because, how do I know that if I write my living will today, 5 years ago or 3 years ago, or from now rather, when that has to be executed, am I going to be in a medical condition to justify this DNR? And if they do it, and I could live a very good life for another 20 years or 30 years, then I'm dying prematurely.
Mm-hmm.
We can't look in that crystal ball.
Right.
We put in the DNR only when we are ready to say that for ourselves. You know, DNI, do not intubate, has everything to do with being fed. You know,
Right.
now again, we don't want to put that in a living will, because how do I know 3 years from now if I'm in some type of situation where I may need that to get by a hump until after I'm able to eat on my own again. So I don't want to put that down unless I really need to do that.
Yeah.
You know.
Well, it's interesting because we have a question from Teresa, who's asking that very question. When is it okay not to use a feeding tube?
Well, John Paul has an allocution that he put out a number of years ago, probably in the 90s, that specifically talked about feeding to artificial nutrition hydration would be ordinary care, not extraordinary care, and therefore it's always obligatory. Now there are certain times when we can take them out legitimately. One condition would be if the dying process has already begun. That nutrition and hydration is not going to be absorbed into the body, and so we don't need to keep that in there to prolong the dying process. If we are at a place where it's too difficult to administer, and that could be a lot of things. Maybe your body can't tolerate the ports or whatever it is that are used for the intubation. If it's infectious or any of those things, we don't need to go there. If death is imminent, and when I say imminent, I'm not talking about next month or 2 months from now. I'm talking about within hours. We don't need to put it in there. So they're very short, small instances where we don't do that. So it's safe for us to say that 99.5% of the time we should always keep it in there.
Yeah.
Except for some of those other conditions. When it becomes too burdensome for the patient, we can't do it.
Well, a couple minutes ago, you used the phrase that you have to be aware of your facility. And all of us over the last weeks became very much aware, I believe it was the Alder Hey Hospital in England, that became embroiled in the case of young Alfie Evans. And of course, Pope Francis very famously offered a helicopter to airlift Alfie to Italy. The Italian government went so far as to grant Alfie Italian citizenship, and may actually pursue, apparently, from what I understand, as of today, some legal proceedings against the hospital or those who might have been involved. Now, we'll see if anything comes of that, but that really brings us to the question regarding Alfie Evans. Now, we don't have all of the details, I understand that, but from what you've seen from a Catholic perspective of moral theology, and of ethical considerations for end-of-life issues and proper care. Just what is your assessment of that whole case, and how do you think it should have played out versus the way it did?
Well, again, we don't know the facts and details of the case, and that will tell us everything. But that's not the point. That's not the tragedy. That's not the immorality. The immorality, as I see it, is a violation of the parents' rights. We see in Catholic theology, in moral theology, especially Catholic social teaching, we talk about this principle of subsidiarity. And subsidiarity directs us and leads us by saying decisions should be made by the lowest level and not the highest level, which means that the free and competent individual has the right to make medical decisions for themselves, and that's what we call autonomy. We know that.
Well, let's stop there just for a second for clarity's sake.
Okay.
The argument that we should bring it to its lowest level seems today to run very counter to the idea of, well, the physicians in this case or the experts should know best and should have the right to impose their superior knowledge on a situation, in this case, on Alfie Evans's parents, because certainly can't you make the argument, they would say, that the physicians, that the experts know best. So how do we argue the subsidiarity?
Well, first off, we've moved away from paternalism many, many years ago. And so that's not an argument that holds any water.
Yeah.
You know, now for us, the parents need to make that decision, not the government, not the hospital. We don't know the financial means of Alfie Evans' parents. Would have been possible for them to fly or airlift their child to to Italy? It's not a very long trip. Could they have done that? The other question that needs to be asked is, would that child have made that trip? Was that child medically able to make that trip without dying?
Mm-hmm.
We don't know the answer to that. But let's assume that the answer is yes, the child could have made that trip. Well, then the hospital is in grave error for not allowing the parents to do this.
Mm-hmm.
Because they say something is correct does not mean it is in fact correct. Now, it could possibly be that the physicians were correct, that he was in a case of futility. There was nothing that could help him. But let the parents make that decision.
Mm-hmm.
You don't make that decision. And if that's superior knowledge, fine. But the point of the matter is, it's the parents who have the right to make the child's decision for him and take them over to Italy. Now, if the child dies in the process going over there, I'm not going to incur, say that these persons have done something wrong or evil. I'm not going to do that.
Right. Given the diagnosis and the prognosis,
yeah,
in this case.
Yeah, I mean, so I guess the questions that need to be asked is, were the physicians correct in saying nothing's going to help
Mm-hmm.
this child? And if that's
Right.
the case, then just let the child die. That's what we call medical futility. That's
Mm-hmm.
where we are. Parents couldn't accept that. Okay, allow the parents to do what they need to do, and if it helps the child, fine. But the physicians in the hospital should not have ever stood in the way.
Well, and a question that sort of flows from that is, for the good of a family, for the good of a patient, under those circumstances in which the patient has no hope of long-term survival, and we're at the point where no treatments will prove effective, why not allow a patient to be moved from the hospital to their home, where they can die surrounded by family, but also can die comfortably and in surroundings that might be more familiar to them?
What you're talking about is the classic definition of euthanasia.
Mm-hmm.
We've bastardized that phrase, or that word in modern times. That's not what it was meant to be understood as. Euthanasia classically is two Greek words, EU, which means good, and thanos, which means death. Mm-hmm. What is death? And to the ancients and to the people, even for quite a while and into modern times, saw euthanasia as the good death being at home, surrounded by your loved ones in a comfortable setting, as free of pain as possible, and then slipping off into eternity.
Mm-hmm. So go ahead.
That's not the way we see that word today. And so,
mm-hmm.
so yes, he could have died at home. which bolsters our case. If
Mm-hmm.
that's the parent's wishes, well, then let the child die at home.
Right. Now, at home, you can receive hospice care. You can receive, obviously, medicine and hydration and nutrition because it's possible. So the question that sort of flows from that then is artificial nutrition and hydration considered a sort of a natural means of preserving life, or is it considered a medical act? And why is there a qualitative and significant difference?
Well, I think the biggest difference is, see, we're in unfortunate times where even some Catholic bioethicists, and I put that in quotes, would use a number of things to justify not putting in nutrition and hydration. Now, I used to use a textbook written by Kevin O'Rourke and Benedict Ashley on bioethics. And Kevin O'Rourke is a great bioethicist, but he's bought into the idea that we just talked about Pius XII's document where he talks about, medical means and spiritual ends and spiritual means. They've used that to justify removing of nutrition and hydration, which is false.
Mm-hmm.
They've used other things. When I emphasize greatly that we have a procedure must offer reasonable hope of benefit, they've changed that to reasonable hope of recovery.
Mm-hmm.
And by those semantic changes and wordsmithing, they're able to switch and to say that nutrition and hydration is not ordinary means of preserving life, but they are means. They're medical ends, and because they're medical ends, this is extraordinary care, and therefore extraordinary care is not obligatory. And so,
how does one go about defining recovery under that context?
Well, you just have to look at the Terri Schiavo case.
Mm-hmm.
Terri was not dying of anything. She would never recover from the PVS state that she was in, but she wasn't dying of anything.
Mm-hmm.
And so to remove the nutrition and hydration was the act that killed her through starvation.
Right.
That was the tragedy.
Which medically is one of the worst. To be deprived of nutrition and hydration in particular is a very, very difficult, painful way to die, isn't it?
Right. That's right. He lasted for 2 weeks.
Right.
She's lasted for 2 weeks because they manipulated the language to make it look like something that she should not have had. Church was totally against the removal of food and water. Ethicists were totally against removing of that. But again, it's the courts overstepping the role of her family, which would have taken care of her for the rest of her life.
Right.
Courts and the government cannot get involved with these issues.
Yeah. Well, in raising the Schiavo case, you have prompted a related question then to that, which is the difference between a persistent vegetative state and what we're obligated or asked to do in a situation like that. First, if you could, for lay people, define what we mean by a persistent vegetative state, and then go from there.
Okay, to do that, we have to look at brain death. And in the two main sections of the brain, and there are other sections I know, but in Terri's case, the brain stem was working. She defecated, she menstruated, she was able to absorb food, digest, breathe, all those various and sundry things she was able to do because her brain stem was still alive and still working. She had a problem with the upper brain, which ceased to make her act, think, and be able to do things that you and I can do. The cognitive.
Right.
So she was not dead. So from a brain death criteria, she was not dead. And so, so in cases of PVS, it's the upper brain that is not working properly or functioning.
Mhm.
Now, there's some science out there, and I don't really want to characterize it because I don't fully know it, and I haven't really read that much about it. But there are places. There's one place right here in Pennsylvania, in Peoria, that's doing neurological rehabilitation.
Mhm.
It's at the Paoli Hospital,
Right.
and they're having wonderful success. Now, is that going to help matters? I don't know the answer to that, but people are moving in that direction. You know.
So, yeah, which raises, to go back to your observation earlier, what is deemed now as extraordinary could in not necessarily long time prove to be fairly ordinary treatment.
Correct. But that would not um, address the issue at hand. And that the issue at hand was nutrition and hydration. And St. John Paul has shut that door. Now, whether ethicists want to accept that idea or not is another story, but he shut that door in his allocation. And that
Right.
nutrition and hydration is always ordinary care,
Mm-hmm.
always care and not treatment. Because if you start looking at it as treatment, you can make other cases, and we don't want to go there.
Right. Well, related to the idea of ordinary versus extraordinary, we have a question from the audience that at what point, this is from Matthew, who wants to know, at what point, if any, can a lack of finances make something that would be ordinary care into extraordinary care?
Yes, that's where we assess benefits and burdens.
Mm-hmm.
And so we're fortunate in the US and much of the first world where finances aren't the issue. But sometimes they can be. Like, for instance, if you're in, you know, end stage renal disease, where you need a kidney transplant of some sort, and you don't have the money, and you know, to be able to help pay for some of that stuff, if your insurance isn't going to cover it, or if you're not, or you don't have insurance, well, then that's a burden. And families and individuals are not required to bankrupt themselves for the sake of medical care. So yes, excessive financial stress can be a burden, and in that burden, we find a justification for withholding the treatment.
Which is very difficult for families, isn't it?
Yes, and you know, the third world and others that aren't as fortunate of us have to deal with that all the time. And
well, go ahead.
No, that was it.
Yeah. So we've had a couple of questions from the audience and also from the web. So I'll sort of pull them all together because they're all asking essentially the same point. And this is one of the questions that I was looking forward to anticipating asking you tonight. And that is, I've been through a number of hospice situations myself with relatives, family, and you could see that the work of the hospice workers, which is, in my personal experience, has been over the years fantastic. But the question that was asked here is, somebody wrote in that he sat with a close friend as he was dying of cancer, and the patient was not responding and appeared to be unconscious, but showed no sign of discomfort. The hospice nurse was giving him morphine every few hours, and I think you know where I'm headed here. Then at a certain point, with permission from next of kin, with the approval from the doctor, she increased the morphine to every hour. I'm not sure what the dosage was, but I was wondering if the nurse was hastening death rather than managing his discomfort. Are there prescription limits and guidelines regarding this? And it's similar to other questions that we've had, is it permissible, especially with something as powerful as morphine, given its impact on respiration and other things, I believe, to administer those? And if so, what are the guidelines? And if not, why?
Well, the main guideline for the administration of pain medication is the principle of double effect. And so let's talk about what that is. Double effect is defined as one act which is good in itself, and it has two effects: the intended good effect and the unintended and evil bad effect. The bad effect cannot be intended. There can be no other ways of doing this, and it has to be a grave reason for using it. So let's look at double effect as it goes with the administration of morphine in this particular instance. The good effect is going to be the relief of pain, but it's going to depress your respiration. And in doing that, this person is going to die sooner rather than later. It will have that effect of hastening death, if you will.
Yeah.
What we have to be careful with is that this is not a lethal dose is not given, because that's not the principle of double effect at all. You can't be given lethal doses on this. Now, what would be a lethal dose for this particular individual that asked the question? Don't know the answer to that, because it has everything to do with the person's weight, his body structure, has everything to do with the comorbidities, has everything to do with his whole being as an individual. So somebody may be able to tolerate X amount of morphine and do well with it. Other people may not be able to tolerate that. Now, was the nurse within her rights to titrate it up? I don't know the answer to that. Maybe yes, maybe no. If in her estimation, or in the physician's estimation, that what she titrated it up to was not lethal, well, then she could have done that.
Yeah.
But if that was known to be lethal, then she killed him. Point and simple.
Right. So we're beginning to appreciate more fully, I think, the complexity of situations like this, as well as the importance of understanding the basic principles that the church offers, and then try to apply them in a way that is most fitting for you. I think would be a good way to put it, would it?
Yeah, and I tell you, over the years, I've taught nursing students, and a lot of times they come in racked with guilt on this one very issue, because they said, I gave them the morphine, and then a couple hours later, the guy died. And we had to go through the whole thing. I had to go through the whole thing with them. What was considered a lethal dose? What was not? Did you give them a lethal dose? Did you not?
Yeah.
Well, we didn't do that stuff. So people just don't understand.
Right.
And they become very, very guilty. I had a situation once in my own family with one of my uncles had COPD, and he was dying. And I was there with my cousin, and the nurse wanted to give him some morphine, and I couldn't really do much about it because I wasn't his son, I was his nephew. But we were waiting for my other cousin to come up from Virginia. And so I said, Ralph, I said, you may want to try something a little bit different, or ask the doctor to try something a little different, because father's probably not going to make it to see Al come back, come to visit.
Yeah.
And so, they took my advice, and they waited, and they gave him something else that was a little, it didn't do everything with the pain, but it did some things with the pain. And able to see his son, and they can go from there. But these things, these are very complex, as you said.
Yeah. Well, it's look at it from sort of the broader perspective, and I know that there have been a few documents over the years from the Holy See and elsewhere, from bishops' conferences and elsewhere, on how does one navigate the issue of pain management, palliative care, and those issues from the standpoint of church teaching. What are some of the basic guidelines for that?
Well, the ethical and religious directives speak to that,
Yeah.
which would be something very good for the audience to have. You just download them, and they're
Yeah.
very, very informative. But anyway, in terms of palliative care, Pius XII made a point to say that we should do everything that we can do to keep a patient lucid while managing their care, which means that, you know, terminal sedation or some of the other things that they do that knock a person out. He didn't put a whole kibosh on it, because sometimes it may be necessary to to get to a person to a place where they're not lucid anymore. But in general, we shouldn't be going there. We should be doing everything that we can do to keep a person with their faculties as best they can, so that they could make amends with the people around them, that they could make amends with God, that they could receive the sacraments, that they could do all these things that will aid this person to go from earthly life to eternal life. And so we shouldn't be robbing a person from that. Now, obviously, there are going to be some cases where, you know, we don't have much of a choice.
Yeah.
But in general, we should be prescribing enough to keep them as best as we can with pain relief. We're not going to get rid of it all, but we could then have to deal with the redemptive suffering that we've talked about before.
Yeah. So sort of flowing from that, that you have a loved one who's in a very difficult situation medically, and then the decision has to be made to remove them from a ventilator, or the machines are literally keeping them alive. As we have seen with other cases in the news, where do you start in assessing, in talking with your doctor about, okay, to euphemistically pull the plug or pull the ventilator, or how do you begin that? Because most people who find themselves in that situation are probably exhausted, they're upset, they're worried about making the wrong decision. It can be a pretty terrifying experience, can't it?
Well, it can be, and we went through that with my mother when she died some time ago. We had her on a ventilator, just the CPAP.
Yeah.
That worked for a while. We took it off. She kept declining. We put her back on it. She take her off. She kept declining, and then the CPAP wasn't even working. So then the decision had to be made. Well, do we put a trach in or we don't? Okay. And in that case, where she was clinically, a trach would be too burdensome for them. We weren't even sure she was going to be able to make the surgery. So we just decided to let it go. And that's when we made a decision to just let death happen. But again, and that what I described was some time ago in bioethics, we called it the Peoria Protocol, which was developed outside of, in Peoria. A guy by the name of Dr. Joe Piccioni put that together. And that was used quite often, to kind of, wean people off of the ventilator when we have to. Another way of assessing this is to take a really good look at where she is internally with brain waves and that sort of thing. But I think the best way that we could start is starting small with the CPAPs and seeing if we can wean them off and seeing how their oxygen levels rise or decline, and then just start now the process of looking at disproportionality, futility, and then going from there. Unfortunately, it has to be a process. This isn't something that we can make a decision overnight.
Right. But some of the terms that you've been using tonight, hopefully are of use in things to listen for as a patient, and questions to ask a physician. But if you've talked a couple of times now about sort of end-of-life directives, of advanced directives, of living wills, and other things. And as our time slowly begins to wind down here, one of the things that I really wanted to get into were those very issues, because we hear a lot today about the need for living wills, advanced directives. And first, what's the difference between a living will and advanced directives?
A living will is a legal document that is almost like a menu of some sort. I will check off. I don't want to be intubated. I want no DNR. I want this. I want that. I want the other thing.
Mm-hmm.
It's loaded with do's and don'ts of what I want or what I don't want.
Which to go back, which, as you advised, can be pretty perilous.
Oh yeah, yeah, and an advanced directive paints with broad strokes. You know, I don't want anything heroic. I don't want anything that's going to be, disproportionate to my care. All those things that we talked about, because people can, in good conscience, say, do everything for me.
Yeah.
Do everything. Even if it's extraordinary, do it. I want it. Okay. Okay. Well, then that's fair enough. You can do that if that's what the patient wants. But that's what the caregiver needs to know. Mm-hmm. I want it or I don't want it. I want extraordinary or I don't want extraordinary. That way, the caregiver has a whole latitude of options for what's going to be the right and best treatment for the patient. Mm-hmm. But once you go with the check, the check says, I want this, I don't want that, I want this, I want that, you're tying everybody's hands. Mm-hmm. And not only are you tying everybody's hands, but you're not doing it in a way that's going to benefit you in the long run.
Right. And a physician is legally obligated to adhere to those specifics, right?
Not necessarily.
Okay.
We're bound to follow our conscience. Mm-hmm. And so if a physician is looking at an order that says, a living will, it says, do not, I don't want to be resuscitated. And he knows in all his experience in practice of medicine and all of his academic knowledge that this person's going to die. Mm-hmm. We could do something for this person. He's got to follow his conscience.
Right.
He must follow his conscience. Yeah. Even the caregiver. Mm-hmm. If the caregiver is not consulted first and sees this living will and it's got something on there that the caregiver finds totally immoral, that caregiver does not have to follow that. Mm-hmm. It's to follow his conscience.
And I'm suspecting that related to that is a physician-ordered life-sustaining treatment, or POLST.
Yeah, very, very dangerous. National Catholic Bioethics, no, it was the Catholic Medical Association put out a white paper on it.
Okay.
And
let's define that a little bit for everybody, and thank you for your patience. It's I'm standing in for the audience tonight and asking for definitions of terms, because, as I said, so many of us who've been through this, there's a waterfall of terminology that just sort of hits you, and it's always good to stay with the basics so that we have some idea of what you're talking about. So when we're talking about a physician-ordered life-sustaining treatment, first, what do we mean by that?
You're giving the physician the authority to make medical decisions for you. And so what you're saying, it's a document. You sign a paper saying, I give so-and-so Dr. So-and-so the permission to treat me in the best way possible. Mm-hmm. Now, a couple things wrong with that. First thing that's wrong with it is, how do you know Dr. So-and-so is going to share your values, your religious values and your moral values? You don't know that unless you really do know that person. Mm-hmm. And know that he or she is, not going to do anything that's immoral from our vantage point. Yeah. In today's time, all we had to do is to look at the Alfie case and the Charlie Gard case.
Mhm.
What are the hospital's financial resources have to play with this? And so
Yeah.
now you have an 80-year-old man who's going in for some issue that he needs that could be easily corrected, but yet now you're giving the authority to the physician to do this, and maybe the physician is the chief of staff and doesn't want to spend the money to treat an 80-year-old when he could treat a 60-year-old. There's something not right with that picture.
Mhm.
So again, the I would never have anyone, if they ask my opinion, to go that route, because if you have a living will with a durable power of attorney, who you know and who you trust, let that person make the decision, not the physician. Now,
Yeah.
again, the Catholic Medical Association has a great white paper,
Mhm.
and you'll be able to read it. It's very good. I read it this morning, and it's very, very good.
Yeah. So it seems to me, and I'm not in any way making light of this, you really need to be careful what you put your signature to.
Absolutely,
Yeah.
absolutely. And you even have to be careful with who is helping you make your living will, because
Mhm.
most of the time people go to their attorneys. They do their last will and testament, and they'll do the living will, and it's a package deal, and that's all well and good. An attorney doesn't have the medical knowledge, in my opinion, that he needs to do this.
Mhm.
And you really should have, you know, some type of medical professional helping you with this,
Mhm.
or somebody that knows, medicine, that could help you put together a good living will. So this way you're not getting, you're and also with the help of organizations like the New Jersey Catholic Conference or the Pennsylvania Catholic Conference, or all the
Yeah.
conferences in this country
And of
have.
course, NCBC, the National Catholic Bioethics Center, has a lot of documents. We'll come back to that in a minute.
Yeah.
But we've had a lot of discussion tonight about patients. We've had some discussion about caregivers. In the time that we have left, I'd like to ask you a little bit about responsibilities of caregivers. What are, from sort of a Catholic standpoint, the obligations and responsibilities of family in a particular situation? Because one of the things we're always hearing stories about the children of elderly or sick who are not willing to have anything to do with their medical care, or in even worse cases, that are rather eager to see a loved one go for their own financial benefit, and yet it's sort of couched or hidden or camouflaged under the guise of, well, we just want what's best for them. What are some of the obligations, and what are things that we need to look out for as potential caregivers?
Well, first off, we had to look at what does Scripture say about this. What does the Ten Commandments tell us? Honor your father and your
Yeah,
mother. And it's
yeah,
not, and we could broaden that commandment, not just your father and your mother, but those persons who you are intimately related to, that you need help with.
hmm,
So we have a biblical admonition to serve, the poor and the needy and the destitute. So that's God's not going to look. We look at Matthew 25, and we see, that whole story about, I was hungry and you fed me. I was all these things, and it didn't go well for the goats.
yeah,
It just didn't go well for them because they didn't do nothing of that.
hmm,
So the faith calls us to be present to our families when they're in need,
hmm,
regardless if they're royal pain in a butts to you.
right,
They still need your care, and as best that you know how to give it.
hmm,
That's the keystone, I think, of Catholic social teaching.
yeah.
You
And
know,
for family members who are long-term caregivers or primary caregivers, or who find themselves caught up in a situation of having a loved one in these incredibly painful and difficult situations, what are some spiritual suggestions that you have, as well as emotional, psychological suggestions for how to not just get through this, but to really understand what you're going through. Again, that redemptive suffering, but also to come out at the other side of this without all the regrets and recriminations that often associate or accompany being a caregiver.
Well, allow me to answer this question with a personal experience. When my mother died, I'm Italian, and you know how Italians are with death.
Yeah.
Um,
You said that, I didn't.
Yeah, trust me, I know. And after she died, I did not have that. I mean, I missed her and I was sad and all that stuff, but I didn't have that sense of, upheaval that most people like also do. And I was thinking about this about a few months later. I'm thinking, I told my wife, I said, am I this horrible person that I'm not like screaming and crying that my mom's died? Or she didn't know how to answer my question. But at the same time, I had to do a lot of soul searching and thinking.
Yeah.
And my soul searching led me to this, that I know that we did everything that we needed to do to make her death right. When she died, it was right, and I knew it was right. I knew it because of my training and as a bioethicist. I knew it in my life as a Christian man. I knew we did all that we knew how to do, and since my family kind of relied on me to make the medical decisions, I knew that I made the right decisions, and I knew that her death was right. So I could go through life atypical of an Italian son and not do the antics because I had no need to do the antics. And so my thought is, when we're struggling with all these things and we have to work each day taking care of our loved one, if we're doing it with right reason, with right spiritual reason, with right medical reason, with all those things, it will pay big dividends after it's all over, temporally and spiritually.
Well, and spiritually, which is I think really vital. So I mean, it is the desire to see our loved ones to have, as the phrase goes, a good death. I mean, St. Joseph, we just had his feast day, is the patron of a good death. And how would you define, from a Catholic moral theological standpoint, a good death?
A good death would be one that was not caused, one that was as peaceful as possible, one that was surrounded by love and care, one that brings healing. Brings healing not just between the child and the parent, say, or the one person to the other relative, but healing with the survivors, that they can come together and see that, we ran a good race, we fought the good fight. It's done now, and there's an old Irish song that says, let the road rise up to meet you until God bless you, and so that's a good death.
I have a feeling that we could have just cut short this entire last hour if we had just started with that question, because in a way that answers everything we need to know in so many ways about end-of-life issues. So thank you for that. I appreciate that.
Yeah, I've often said that the foundation for the definition of good morality and good bioethics is love.
Yeah. And you don't always get that in an institution.
No, you don't.
Right. Well, we're just about out of time, Stephen. So where can people go? Where do you recommend they go for online resources? I know one of the ones that we've mentioned it several times is the NCBC, the National Catholic Bioethics Center, which I know you can find at ncbcenter.org, and they have a lot of publications, including, I think, a beautifully written guide to end-of-life decision making. What other recommendations do you have?
Well, that would be my primary one because you can get anything you want from there. But there's a
Yeah.
there's a membership fee, but I tell you,
Okay.
it's not much, and the
Right.
fee will give you all their resources. You know, the Catholic Bioethics, Catholic Medical Association also is very, very helpful. You don't have to be a physician to join. It's cathmed.org,
Mm-hmm.
and they have access to white papers and conferences and various things that would be helpful to people. But I really do think that the go-to place is the NCBC.
Yeah, so that's ncbcenter.org if you're looking for information. Well, Stephen, we are unfortunately out of time. This has been a very helpful conversation, I think. I hope that all of you who are in attendance here tonight have also derived some benefit from it. Perhaps you've come up, you're going to be leaving a little more informed. If any of you find yourselves in many of the situations that we've described tonight, do know that as a church, we are supporting you. We are praying for you. And I pray that some of the information that you've received tonight will be useful in making those sound prudential, but especially the sound moral decisions in light of the teaching of the church. Well, Stephen, again, thank you so much for being with us tonight.
This is wonderful.
Yeah. If you would like a lot more information on these types of decisions, but you'd also like to study more about theology, in particular moral theology, if you'd be interested in taking Steven Bozza's course on moral theology, which is a graduate course, please go to cdu.edu to explore our website for courses, continuing education, and all of the educational opportunities that are out there. That concludes our webinar for tonight. Thank you so much for joining me. I pray that you have a blessed May, a blessed summer, and a blessed rest of your year. Until next time, and our upcoming webinar, please stay tuned for that. I'm Matthew Bunson, your host for this evening. My renewed thanks to Steven Bozza, and on behalf of everyone at the Catholic Distance University, please take care and God bless.